22. Yes, correct. Anyway.
I think, good evening, friends. Sorry to interrupt, sir. And I think the faculties are tied up at various places. I think today it's going to be our in-house faculty. Somprakash Basu sir is just winding up a meeting. I think Ganesh Babu sir is already traveling to Bangalore. I never thought about it. And Dr. Rajan is also traveling somewhere. So I think we have to be with our faculty. So Prakash sir has promised to join a little later. So I thank both the students, and Rajgopal sir was kind enough to organize permit the student from his hospital to present Dr. Suraj. He will be presenting on right leg for Samas. And then we have Dr. Devopriya. Again, thanks to Professor C.D. Narayanan sir from Sri Ramchandra Medical College. She had a very limited notice, but she was kind enough to quickly send in the PowerPoint. So we have 2 cases, right leg fossa mass and oral cancer for the evening. So we'll have the student from Dr. KMC Manipal, Dr. Suraj, to start the first case. Dr. Suraj, introduce yourself. All the faculty here know about your position. They will definitely help you out. So don't be having any worries, both the students. We are here to help you. This is going to be a teaching session. So feel free. If you find difficult to answer, please tell so. The faculty will definitely guide you. Thank you, Dr. Suraj. Good luck to you.
Yes. Good evening, respected staff. I am Dr. Suraj, second year resident in general surgery, Kasturba Medical College, Manipal. Today I will be presenting the first case. Shall I start, sir?
Please go ahead.
Yes, go ahead.
This is a case of a 40-year-old female patient who is nilpremorbid, housewife by occupation, hailing from Chikmagalur, presented with complaints of easy fatigability since 3 months and pain abdomen since 3 days. History of present illness. The patient complains of easy fatigability since 3 months, which gradually progressed over the 3 months. The patient is unable to complete daily household activities and unable to walk more than 20 meters. The weakness is associated with diarrhea since 3 months. The diarrhea is 2 to 4 times a day, yellowish in color, presence of occasional blood in stools. There's no complaints of mucus in the stools or black tarry stools. It's also associated with vomiting since 3 months, 2 to 3 times per week, containing food particles, non-bilious and no blood stain. Patient also complained of pain abdomen since 10 days in the right lower quadrant, which is insidious in onset, non-progressive, colicky type, aggravated on lying in right lateral position, and after some time after taking food, and it is non-radiating. The patient also gives history of weight loss of 14 kgs in last 6 months. The patient measured about 60 kgs in February and 46 kgs at present. There's no history of abdominal distension, no history of jaundice, no history of fever or night sweats. Patient took treatment for all these symptoms at a local physician, where she was managed conservatively with occasional intravenous fluids and hematinics. Patient received 3 units of blood transfusion 2 weeks back in view of low hemoglobin and was referred to Kasturba Hospital, Manipal for further management. Past history, there's no history of diabetes, hypertension, hypothyroidism, or pulmonary tuberculosis. Patient had a history of 2 cesarean sections, one in 2005 and another in 2009. Personal history, the patient is non-vegetarian. Patient complains of decreased appetite since 3 months. Sleep is normal. No history of smoking or alcohol consumption. Family history, 30 years ago, the patient's father was operated in view of large intestinal pathology. The patient is not aware of the diagnosis and the documents are not available. The surgery done was a midline laparotomy and no stoma was created. No history of ovarian or uterine malignancies in other family members. Menstrual history. Age of menarche is 13 years. The menses lasted for 3 days in a cycle of 28 days. It was regular, no menorrhagia or blood clots. General examination.
No, hang on.
Suraj, you stop.
Hang
now.
on, Suraj.
Dr. R.N. Sahai will ask you some questions, okay, related to history, okay?
Yes.
Yeah.
Yeah, let's go to your first slide, please. Before that, first, this
Yes.
complaint song.
Yes.
40-year female nil pre-morbid. Why did you give so much importance to this? Second line is just straight away pre-morbid. Why did you give? Any
Yes.
reason for it?
No.
In chief
No
complaint, date of look, what's the name? Suraj.
Yes, sir.
Chief complaints, date of examination, then comes easy fatigability, pain abdomen. This doesn't come under chief. It just says 40-year lady, a housewife of from Chikmagalur, complaining of fatigability since 3 months. Is it since 3 months or for 3 months? What would you say? Since 3 months or for 3 months? And why?
For 3 months.
Why?
If the duration is mentioned, we have to use
Right.
for.
If you're sure of when it started, you say since this date. Otherwise, for so many people, right? And pain
Yes.
abdomen for 10 days. Okay. So she has fatigability and pain abdomen. Let's go to your
Yes.
next slide. So this slide has to be changed. Okay. It
Yes,
is chief complaints. 3 months progressed. Now, what do you mean by fatigability? Unable to? Is it progressive? Is it
Yes, sir.
became worse?
Progresses. Initially, the patient used to feel fatigue at the end of the day, sir. But gradually, over 3 months, the patient is not able to finish her household activities.
Okay, that's good. Okay. Diarrhea also since 3 months. Now, you didn't tell us about complaints in her chief complaints that she's having diarrhea. So it is fatigability with diarrhea,
Yes.
right? So this is a new
Yes.
complaint. Look, a history of present illness should not throw up a new complaint. Isn't it?
Yes, sir.
Right?
Suraj, your history is for 3 months, 6 months, or how many days you are asking the history?
Sir, the weight loss is since 6 months, sir. Other complaints.
I just want to know, you are now suddenly bringing a weight loss for 6 months, but your entire complaint is for 3 months. What is that relationship you are bringing? When the present illness, when we say some chief complaints with related to that, or when you are starting the present illness, that is the duration, that is the present illness. So your present illness period is for 6 months or 3 months you are going to talk. You know in the history, you know, she has some problem last 6 months.
Yes. 6 months.
She is losing weight since 6
Yes,
months.
sir.
And
Yes,
that
sir.
should be brought in. That's the first priority. Then not coming after that, you should not do it.
Okay.
Can you explain somebody having both diarrhea and vomiting? What is the reason for this? Because this patient has diarrhea for 3 months, vomiting for 3 months.
Yes, sir.
How will you explain this?
Sir, the patient is having easy fatigability, and the local physician has started on hematinic, sir. Might be because of gastritis, the patient might be having vomit.
No, you never said about pain abdomen due to gastritis. There is no history when you are talking about the pain abdomen is right lower quadrant.
Yes, sir.
This pain must be in the epigastric.
Yes.
Your history is not revealing she had a epigastric pain or a gastritis. But just because you say diarrhea since 3 months, 2 to 4 times a day, vomiting 3 months, 2 to 3 times a day. Is it a food poisoning, acute condition, or obstructive lesion? Or what is the reason? What is your mindset thinking that these two can go together?
If the patient is in subacute obstruction, 2 to 3 times per week vomiting she is having, sir.
Okay. So little more history you should have elicited, and what is that relation to the vomiting? What is that? The really you are talking about diarrhea. Did she has 4 times diarrhea every day? And that is for the last 3 months continuously. You are saying that everything is happening within the 3 months, and little more. You need to put some more clarity on that and how you are happening. Whether what type of diarrhea it is. Is it a spurious diarrhea or a mere diarrhea? What is a spurious diarrhea?
Sir,
Good morning diarrhea or spurious diarrhea?
spurious diarrhea is
He
Over-
passes stools, but it will not have
overflow.
stools. It is only having the mucus.
yes, sir. Only mucus. will be-
You must quantify and qualify this diarrhea. Is it a dysentery? Is it a diarrhea? Is it a
Yes.
mucus and blood? And second, you are saying that it has a blood and no, not black tarry. What do you mean by that?
Presence of red colored bloods are not the black tarry stools, sir.
You are expecting from right side colon, the blood all the way it passes, and still it comes as a red blood. Will the color change or it will be still red?
It will change, sir.
So what is there in your case? You can get fresh frank blood if it is acutely coming, you can get. But commonly for all these years, if she is having the same blood, you need to be a little more conscious. And
Yes,
are you
sir.
sure your pain is a colicky type of pain?
Yes, sir.
What do you mean by colicky pain?
Squeezing type of pain, which increases and stays for a few minutes and then decreases again, sir.
What is the cause
Usually
for-
in,
What is the cause for that?
sir,
What is the reason for that colicky?
when the luminal structures become obstructed because of stretch of the bowel, or the patient will be having colicky pains.
Right. It is strange to think a patient who has an obstruction you are expecting, but presenting with a diarrhea for 2 to 3 times.
Yes, sir.
So again, be qualified whether, look, really you are meaning typical colicky pain. How much time it lasts? Colicky pain?
Last 2 to 5 minutes, sir.
Then it relieves completely.
Doesn't relieve completely, sir. Goes to a baseline and it increases.
So maybe it is not a colicky pain. The patient has a continuous pain is there. Sometimes it is exaggerated, something. Can a colicky pain produce vomiting?
Yes, sir. Because of pyloric spasm, the patient might have vomiting associated with
Pyloric?
colicky.
Pyloric?
Pyloric spasms, sir.
Why? Why pylorus? When you have a problem in sigmoid and ascending colon, why the pylorus goes for spasm? What is the logic behind that? What is the nerve supply of the pylorus? What is nerve supply for ascending colon? All are vagus up to the
Yes, sir.
part of the
Parasympathetic
control.
vagus.
But a reflex pyloric spasm. Okay. And in the past history, you have mentioned loss of appetite.
Yes.
Decreased appetite since 3 months.
Yes.
Why you are taking that to the past history? Sorry, personal history. Why not it is in the present history? See, that is important. Patient is anorexia,
Yes, sir.
fatigability, a loss of appetite, loss of weight.
Yes,
All this should be brought in a present illness in an order. Don't
Yes.
take it separately. Suddenly you are coming and saying loss of appetite.
Okay, sir.
Suraj,
Yes, sir.
yeah. Look, she is having loss of weight. She's having
Yes, sir.
diarrhea. She's having vomiting. She's having decreased appetite. And what else? And bleeding per rectum.
Yes, sir.
So there's a whole array of symptoms.
Yes, sir.
But your whole history is we're not getting a pattern out of it.
Yes.
It could be subacute intestinal obstruction, could be tuberculosis, it could be malignancy, It could be just ulcerative colitis, it could be Crohn's, right? Okay. Also, so, right. So let's get your history corrected. Let's go back to your complaints of, right?
Yes.
Okay. So 6 months ago, she was absolutely okay,
Yes, sir.
right? Then she noticed that she's losing appetite and weight.
Yes.
Is
Weight
it?
since 3. Yes, sir.
She started losing weight just like that weight, or was it with appetite or something else? You just can't just lose weight without any symptoms. There's
Yes.
something wrong somewhere. There has to be some symptom associated with weight loss. Right?
The loss of appetite and diarrhea, she
This is
she
3
was
months.
giving.
This is
Yes, sir,
3
3
months, isn't
months.
it?
Yes, sir. Yes.
I can understand. Okay, since 3 months she's been losing weight. Look, okay, why do you think she was losing weight for the last 6 months and then getting the symptoms later on? Can you explain it?
No, sir.
I mean, I can't. Right? So there's something wrong somewhere. Right? Okay. So with your history now, what do you think you're dealing with? What could be the differentials which you're dealing with? You've done your history. Can you
Yes, sir.
summarize the history? Can you summarize the history?
Yes, sir. 40-year-old patient with the complaints of weight loss in 6 months, sir. Weight loss of 14 kgs in last 6 months, and easy fatigability since 3 months, diarrhea since 3 months, vomiting since 3 months, 2 to 3 times a week, sir. Pain abdomen since 10 days.
Okay.
Yes.
Let's get this done. Now, what about diarrhea? Is it associated? Is there any precipitating factor for it? What is
No,
is it absolutely watery? You said there's occasional blood. How much is the blood? Is the whole diarrhea bloody, or is it mixed with stool? Or is there any form stool there? We're not getting anything.
yes.
You get
Why
me?
the pain is aggravated by food intake?
Sir,
You
probably,
mentioned,
yes,
colic
sir.
after food intake.
Yes, sir. Probably the patient is in subacute obstruction, and after some time after food intake, the patient is having pains.
Suraj, with subacute, there will be some sort of distension of abdomen. You can't have subacute without any distension of abdomen.
Okay, sir.
It may not be very prominent, but there will be some distension.
Yes.
Right.
Patient who has a 3 to 4 times diarrhea per day cannot have the subacute obstruction.
Yeah.
You say there is a 2 days he is not passing stool, suddenly she passes stool. That's something we can think of. This you are saying absolutely every day she has a diarrhea for 2 to 4 times. So thinking in terms of subacute obstruction is little far-fetched. And
Okay.
what relationship which comes, you just think why she is going to get a pain on right lateral position, why she is going to get the pain on a food intake, and you are putting this non-radiating. Can you get a colicky pain radiating?
Yes, sir.
Where colicky pain where radiates?
Radiates to back.
Colicky pain.
Yes.
Suraj, I would like to tell you something. Look, when you take your history, you should be able to explain the symptoms.
Yes.
You just can't say because the doctor was giving her hematinic, so she's getting pain abdomen, then she's getting subacute intestinal obstruction, so that's why she's having vomiting, or there's pylospasm, or reflex pylospasm, or that blood, how I can't explain the blood. Look, things are not being explained by your history, right? Have you taken any history of urinary complaints?
Yes, sir. No history of burning micturition.
Any hematuria ever?
No, sir.
So all this has to come out, Suraj,
Yes, sir. Yes.
right? You've got some pathology in the right iliac fossa, isn't it?
Yes, sir.
So what are the structures within the right iliac fossa in which you'll think of? You've got the gut, you've got the appendix, you've got the kidneys,
Yes.
right? You've got the ureter. In a lady, you've got the ovaries and the tubes,
Yes.
right? You have the retroperitoneum. So you got to think of everything.
So
Okay.
Suraj, I just want to enter in and just say that what everyone is trying to tell you is that it may not match with the whatever we have in mind. For example, vomiting containing food particle, non-bilious. So means what? Does it match for say obstruction per se?
No, sir.
So that may be something connected to what? Maybe esophagus, maybe stomach related issues, correct?
Yes,
So in
sir.
other words, just to keep, since PGs are here, how do you differentiate regurgitation from vomiting? Do you know what is regurgitation and what is vomiting?
Yes.
Can you just say? Yes. Regurgitation is esophageal contents.
Yes, sir.
So stomach immediately they will sometime bring out see whatever it is food particles. So in other words, these somehow as Dr. Sahai sir beautifully said that if there is a colicky pain, some amount of distension. See, our patient may not be very intelligent to say that. Only what happens sometimes the patient try to change their food style, food habits, and so that they will take a little bit only and they say "Ila, everything is okay like that. But whatever it is, sometimes we will not be able to explain. So as far as possible, everything should be taken carefully. All these questions. When patients is blood in the stool, just to give me 2-3 examples of massive bleeding per rectum in general. Do you know some causes for massive GI bleeding?
Yes, sir.
Tell.
Mesenteric ischemia and ulcerative colitis.
Yes, possible. Anything else? There are a lot of blood, mucus, young age. This. What is the other left-sided disease? You get really massive bleeding. So diverticular disease. See,
Diverticulitis.
what are the diseases where you get suddenly massive bleeding? Angiodysplasias, diverticular disease. Sometimes. So then blood mixed with the stools, spurious diarrhea. So
Yes, sir.
little more details. That is what everyone is trying to tell you. As far as this patient is concerned, I think since all senior examiners are here, just for a clarification, patient came and started with not my case anyhow, fatigue and all this in retrospective. When they asked, they said she said she has been losing 6 months weight loss. Probably she can put it as in the history of present illness, correct? Retrospective.
Yes, sir.
So
It should
patient
be in the
has-
present illness. It's better to be in the present illness.
Okay, sir. Please go ahead.
Suraj, you talked about 2 cesarean sections, no?
Yes, sir.
Any other surgery you asked the history? Is there any surgery would have precipitated development of the malignancy in the colon? Have you asked anything about gallbladder surgery?
No, sir. No history of cholecystectomy.
Is there any significance in that?
After cholecystectomy, the patient is more prone for CA colons.
Why? The bile acids will come as a salt. It will not, the complex will not form directly. It will be. So, because a 40-year-old lady, so the lady, when you are talking about that, even sometimes breast carcinoma surgeries. So, surgically, yes, you can say there is no surgery, but you must be ready with that. What are the surgeries that really you are meaning to ask for the past history?
Yes.
Okay, I think you can go ahead for examination.
General examination, sir. The patient is conscious or coherent, oriented to time, place, person. The patient is moderately built and poorly nourished. Height of 156 centimeters and weight of 46 kgs. BMI of 18.9 kg per meter square. Pulse rate of 84 per meter, sir. Blood pressure of 110 by 80 millimeters of mercury. Respiratory rate of 14 per minute. The patient is afebrile, sir. Pallor is present. There was no icterus, no lymphadenopathy, and no pedal edema. Abdominal examination.
Go ahead, Suraj.
Yes, sir. Per abdominal examination, sir. The patient is after due consent, the patient is examined in supine position, exposed from nipple to mid thigh, sir. On inspection, the shape of the abdomen is normal, sir. The umbilicus is in midline and inverted. There is no distension in the flanks. Phalanstein scar is present, sir. There is no visible pulsations or peristalsis. There are no visible engorged veins. No visible fullness or mass per abdomen, sir. All quadrants are moving correspondingly with respiration. Hernial sites are normal, sir. On palpation, the abdomen is soft, mild tenderness is present in the right iliac fossa, sir, and no guarding or no guarding or no restricting. A mass of 6 into 4 centimeter present in the right iliac fossa, extending into the right lumbar region, sir, which is spherical in shape. The extent of the lesion is the medial border is 4 centimeter lateral to the midline, sir. The lateral border is 10 centimeter lateral to the midline. Superior border is 2 centimeter above the level of umbilicus, and inferior border is 4 centimeter above the right inguinal ligament in mid-clavicular line, sir. This is the line diagram.
Dr. Nagaraj Kagali, Appo A7, please mute your phone. Sound is coming, please. Yeah. Thank you. Yeah. Go ahead.
This is the line diagram, sir. The surface of the swelling is nodular, sir. Borders are irregular. The swelling is the lump is hard in consistency. Minimal transverse mobility is present, sir, and there is no vertical mobility. Mass becomes less prominent on leg raising test, sir. There's no mobility of mass on patient lying in left lateral position, sir. There are no pulsations over the swelling, no hepatomegaly, no splenomegaly, no other masses palpable in the abdomen. On renal angle examination, no fullness in the renal angle, sir. The mass is not bimanually palpable or palatable. There is no palpable nodule in the umbilicus, or there is no palpable nodes in the left supraclavicular region, sir. On percussion, resonant note is present of the mass, sir. Liver span is of 11 centimeters and there is no free fluid in the abdomen. On auscultation, bowel sounds are heard, sir. Normal. There is no bruit over the mass, sir. On parectal examination, is normal, sir. There is no blood staining of the gloved finger. There is no nodularity or mass over the pouch of Douglas. Systemic examination is normal, sir. Respiratory system, bilateral air entry is equal and vesicular basins are present. Spine, no paraspinal tenderness is present, sir. CVS and CNS are normal, sir. Examination. Provisional diagnosis is carcinoma cecum or ileocecal tuberculosis.
The two extremes diagnosis. With a short duration, 3 months, you are making a diagnosis of ileocecal tuberculosis.
Sir, most probably carcinoma cecum, sir.
So why do you add ileocecal tuberculosis? That means you are thinking in terms also. None of your histories were in favor of ileocecal tuberculosis. Would have put ulcerative colitis, Crohn's. That is much more because you had you can still explain. Okay, no problem. You said abdomen on inspection you couldn't see any mass.
No, sir.
And what is the size of your mass?
6 into 4 centimeters, sir.
The shape, how can it be the shape is spherical? What do you mean by spherical?
Sorry, sir. Longitudinally.
But most obvious thing is you said it is hard, surface is also irregular, but your percussion is resonant.
Sir.
How can a hard mass produce a resonant sound?
Bowel mass.
Bowel, you are feeling the mass, that is a bowel mass, that is becoming hard, surface is nodular, that is a very thin build, so you are able to feel it very fully well. But being a resonant, if you say it is a resonant, even in a cecum, even impaired resonant is not accepted. Most of the time it will only become a dull. You will not be able to state a resonant sound on that unless your small mass, entire other colon is on potential to that. That is a
Yes.
very, very rare. Even then, it will be expired resonance. But making it as a resonant is not a good thing.
Okay, sir.
And I mean, I'm still not, I mean, probably, I'm not able to understand when you say there's no mass is seen on leg raising test, mass decreases in size. And how do you explain that? It is, you feel the
Sir,
mass and
on palpation, the mass is becoming less prominent on leg raising test, sir. On
only
inspection,
this
there is
become
no
less
mass.
prominent on leg raising.
The mass is intra-abdominal, sir. So on
What?
leg raising,
So
the
the mass you are able to feel completely. You are able to palpate a mass for 6 into 4 centimeter mass. You are able to define. By leg
Yes.
raising, the mass will decrease in size.
No, sir. Not becoming less prominent, sir. Not able to palpate completely.
No, usually that we are mentioning when the mass is obviously seen, visible outside, you want to leg raise to make it whether size is decreasing or not. It is invariably by palpation, already we are feeling the mass. That
Yes,
what you
sir.
are feeling the mass, the decreasing in size is a very rare. That is palpability will be difficulty. That is a different point.
Yes.
And then you never said whether the mass is moving with respiration.
Sir, as the mass is present in right lower quadrant, usually the right lower quadrant mass will know the respiration.
Mass will
Usually the mass in right lower quadrant will not move with respiration.
all the mass. Okay.
Superior quarter is also palpable.
Is it a reducible anytime?
No, sir.
If you said it is a colon, so if it is a colon, if it's a large, if it's some small obstruction, it will go on for a bulging. So you can reduce it with the gurgling sound. That is also not there because everything is become a solid here. You said it
Yes,
is
sir.
hard structures. Okay.
Yes, sir.
So, sir, any other questions? And once you are you look for the renal angle, no?
Yes, sir.
For what?
Sir, as the mass is slightly extending into the right lumbar region also, so I examined renal angle also, sir.
So normally, what will be the sound there?
Sir,
What will happen to the renal angle normally?
if there is a hydronephrosis, then or if there is renal cell carcinoma, then the renal angle fullness will be there, sir. And the swelling will be bimanually palpable and bilautable.
Your swelling is also bimanually palpable.
No, sir, not bimanually palpable.
Okay. Why you want to look for the nodules in the umbilicus?
For if there is any metastasis and cystomerism of nodules.
Supraclavicular node is also. And how
Okay,
do
no,
you expect from a mass in the right ilia fossa goes to the supraclavicular?
Sir, via the lymphatic drainage from epicolic, paracolic, and principal nodes, the malignancy might metastasize into the thoracic duct. And as the thoracic duct traverses and ends in the junction of left subclavian and left brachiocephalic tract. Sir. At that point, there might be spread to the transcapsular spread to the lymph nodes in the left supraclavicular.
So how you are going to proceed?
Provisional diagnosis of carcinoma cecum, sir. Then
How do you exactly come to the conclusion? Is the carcinoma cecum or is it ascending colon or carcinoma cecum? How do you know?
sir,
You said your part is a fixed structure.
yes, sir.
Cecum is mobile or fixed?
Fixed, sir. Minimal transverse mobility is there, sir. Vertical, it's not mobile.
So cecum is also fixed.
Ascending colon is more fixed, sir.
So why do you but very categorically say it is a cecal malignancy? Why not is the right-sided colonic malignancy?
Sir, it might be.
Probably you are looking back into your CT finding and then coming to that it is a cecal malignancy. So clinically, how do you say it is a cecal malignancy, not ascending colon malignancy?
Sir, minimal mobility is there, sir, and transverse mobility. And most of the mass is in the right iliac fossa and little bit is extending it to the right lumbar region.
Okay.
Suraj, what are the
Yes, sir.
characteristics of a right-sided malignancy?
Sir,
History and present and clinical examination.
in history, the patient will have fatigability because of anemia and blood loss, sir. And clinical presentation also, the patient present with blood in stool, sir, rather than with obstructive symptoms.
So anemia, asthenia, and
And anorexia. Yes.
anorexia. Okay. Now, are cecal lumps palpable usually? Malignancies. What are the types, histopathological types?
Adenocarcinoma in the cecum, sir.
No.
Morphologically,
Morphology.
what is you have one type, ulcerative type.
Yes, ulceroproliferative type will be present, sir, in the right-sided malignancies.
Right. So, will they cause obstruction?
No, sir. Mostly, no, sir.
No. So, why is your patient having obstruction? Why is
Sir,
the patient having diarrhea? Will it cause diarrhea?
Yes, sir. Secretive diarrhea will be present, sir, in right-sided malignancies.
Right. Okay.
This patient's father also, you said some unknown disease he has affected. Anything significant on?
I'm sorry, sir.
Her father 30 years back, her father also died.
What is that? What is that?
Yes, sir. Father also was operated, midline laparotomy was done, sir. For large intestinal pathology, he was informed.
So any significant on that?
Yes, sir. If the patient is also 40-year-old, sir. So in hereditary non-polyposis colon cancer, mostly right-sided colonic malignancies occur, sir.
What is Amsterdam criteria?
Sir, Amsterdam criteria tries to define the hereditary non-polyposis colon cancer, sir. If the in family history of any 3 or more individuals who are having colonic or endometrial or renal cancer, sir, and 2 of them should be first-degree relatives, and the cancer should run in 2 or more successive generations, sir.
You are expecting Lynch 1 or Lynch 2?
Lynch once colorectal.
What is the defect you have in the Lynch?
Mismatch repair of
What is the
MA.
transformation? Once you diagnose HNPCC, how much will be turned into malignancy?
Sorry, sir.
How much of the persons who have HNPCC polyps will turn into malignancy? Suppose somebody has a polyp, familial polyp,
Yes, sir.
and HNPCC, which will turn into malignancy More.
In familial adenomatous, it is 100% malignancy risk is there, sir.
So right-sided colon with the family history. I think you have to do the checking for this as a mind. Could be a possibility of a hereditary. Suppose you think that, what you should do?
First, all the genetic counseling and microsatellite instability has to be checked, sir. Because of mismatch repairs, repetition of the sequences will be there, and microsatellite instability.
Being a young like that lady, you need to have that in the mind also.
Yes.
Mr. Dr. Prabhagar sir, Dr. Prabhagar, please mute your phone. Dr. Prabhagar, please mute your phone.
Yeah, Suraj, just one or two small clinical points before. One is that right-sided are more common in women, and remember, intersusception is notorious, right-sided.
Yes.
Right-sided colonic.
I'm sorry, sir.
Dr. Prabhakar.
Dr. Prabhagar.
What I'm trying to tell is the right-sided tumors can present as intersusception.
Yes, sir.
They can
Yes.
also have acute appendicitis-like features. And you
Yes,
said sometimes backache, it can have a sometimes no psoas, the iliacus, iliopsoas infiltration.
Infiltration, yes.
Dr. Prabhagar, please.
நாளைக்கு கூட அதனால நார்மலா போகணும்னு சொல்றேன். மாத்திரை விட உடனே வயிறு எரிஞ்சிரும். ரொம்ப முக்கியம்.
Suraj, diarrhea will be more common in tuberculosis, Crohn's disease, or carcinoma? Presentation.
Sir,
Suppose this question is asked.
in carcinoma, sir, the ulcerative surface.
No. Diarrhea is actually, Crohn's has got a more incidence compared to even tuberculosis than compared to carcinoma. That's why. So we are not telling you it's a Crohn's disease, but because significant weight loss is there. So we all know the blood in the stool and everything, but just you have to keep it in mind. Since a lot of symptoms, patient has upper GI symptoms, lower GI symptoms, then comes all these things, severe weight loss, diarrhea you are telling, of course. So keeping that in mind, inflammatory bowel disease, not that they will definitely ask you features of Crohn's. Crohn's can affect esophagitis, stomach and all these things. Ulcerative colitis will not affect. So just to keep you alarmed, not that they will, this is not about diagnosis. This is about how you have broadly understood the symptomatology and description of the each disease. Okay, behavior.
Yes.
No fever. So, but that does not rule out tuberculosis. You understand?
Yeah, yes.
All the things which we talk about, significant weight loss is for the patient.
நல்ல இடத்துல பரம சொல்றேன், வெறும் வயிற்றுல தான் கொடுக்கணும். அது மட்டும் ஒண்ணு பண்ணிக்கோங்க.
Prabhagar, Dr. Prabhagar, please mute your phone.
ஆமா, அது வந்து ஃப்ரீ தைராய்டு. ஏன்னா யாரும் சரியா கூட பணம் வெங்கடேஷ் கேட்பாரு, இருந்தா அதை சொல்லி அனுப்பு.
சார்,
யார்கிட்ட கொடுத்துறாதீங்க, எந்த காரணத்துக்கு வந்து கொடுக்காதீங்க.
சார்,
எதுக்குமே கொடுக்காதீங்க. இதுதான் வந்தது.
Dr. Prabhagar.
Change the slide. At least we can move on to some.
Yes, sir.
At least.
ஒன்னும் கவலைப்பட வேண்டியதில்ல.
Investigation, sir, to look for hemoglobin because the patient was complaining of physique, fatigability and anemia. Hemoglobin of 8.2 was there, sir. Total counts of 7,600 and platelets of 3,90,000.
சும்மா இருக்க கூடாது.
Ultrasound of abdomen and pelvis, sir.
அதனால நிறுத்தாதீங்க.
It was suggestive of significant hypoechoic wall thickening in the ascending colon and cecum with a maximum thickness of 16 millimeters. Sir. Increased ecogensity of adjacent mesenteric fat. Few subcentimetric hypoechoic pericolic lymph nodes are noted, largest measuring 1.2 into 0.7 centimeters, sir. Cholelithiasis was present, sir. No evidence of cholecystitis. Liver is normal in size, increased echo texture, and no obvious focal lesions present in the liver, sir. Then colonoscopy, sir.
சரிம்மா, போயிட்டம்மா.
Colonoscopy, ulceroproliferative slough covered growth was noted in the ascending colon, sir. The biopsy was taken, and the biopsy was suggestive of invasive tumor compound of cells, which having pleomorphic nuclei and frequent mitotic figures. Submucosal infiltration was also noted, sir. Diagnosis of poorly differentiated adenocarcinoma was made.
நான் சொல்றேன். சரிம்மா, போயிட்டாங்க.
Suraj, wait now. Suraj, wait. Let further examine. They ask you investigations, etc. Jailal sir, please take over.
Yes.
No, you have done the colonoscopy first and the biopsy, or the CT first?
Colonoscopy and biopsies.
So, what is the indication for colonoscopy and how do you do that?
Sir, here as we are suspecting the right side.
Go ahead.
We are suspecting the right-sided mass, sir. So for with differential diagnosis of carcinoma cecum for right-sided colonic mass, we proceeded with colonoscopy, sir. After adequate bowel preparation, sir.
So you could reach to that level without any problem?
Yes, sir. Until mid-ascending colon, the colonoscopy was done, sir. In the mid-ascending colon, this ulceroproliferative growth was noted, sir.
Okay, this is in the ascending colon. That is always better. You in the clinical point, you say it is a right-sided colonic mass than putting in a particular area. That will be a little difficult on that.
Actually, this was actually, sir, going up rather than going down. That is why it was looking more of ascending. But I think in the exam better if they say right-sided, and in particular, if they ask, they can probably tell. No? If they ask.
Yeah. That is
Yes.
Okay.
So your biopsy has confirmed.
Yes.
Have you noticed any other polyps in the colonoscopy?
No, sir. The rest of the colon was normal, sir. There were no polyps in the rest of the colon.
Because one of the saying that always adenoma leads to the carcinoma.
Yes, sir.
Suppose you get an adenoma, can you say that? Can you by colonoscopy? Can you say what type of adenoma it is?
If it is sessile or pedunculated, we can say, sir. And
Which adenoma is more dangerous? What percentage of tubular adenoma will turn into malignancy?
As the villus component increases, the risk of malignancy increases, sir. From tubular to tubulovillous to villus polyps, the risk of carcinoma increases.
Suppose you are seeing a villus polyp, what you will do?
Based on the size of the polyp, sir, if it is less than 2 centimeters, endoscopic transmucosal resection can be done, sir.
If it is a pure villus polyp, when you are suspecting, because the possibility of turning malignancy is more than 40%, it is better to go for a resection.
Yes.
People are on tubuloadenous. So what is one thing for doing colonoscopy is sight. Second thing is look for polyp. Any other things you will look in the colonoscopy. What is synchronous tumor?
If there is another malignancy at the same time developing in the other part of large intestine, sir, unrelated to the the
Colon
tumor.
is also more prone for that, to developing
Yes,
a syndrome. So when you are
Yes.
doing a colonoscopy, all these you have to understand. Whether you are going to look for the any polyps or the more, because your surgery is going to be extending on that. Similarly,
No, sir,
if it is a same segment, you can go for a
Nothing
segmental.
there,
Otherwise, you have to extend your this segment.
Extent.
So
Yes.
that is an idea behind doing a confirmation you have got.
Yes.
So how will you stage that?
Sir, based on the depth of infiltration, sir, in T1, the tumor is invading up to the submucosa, sir. In T2, it is invading until the muscularis propria. In T3 until the subserosa, sir. T4A is into the visceral peritoneum and
Colonoscopy
T4B
cannot
into
see
the
everything. No? You are only seeing the individual. You see the
Sir,
staging.
in endoscopic ultrasound has to be performed, sir, to see the depth of the invasion.
ஞாயிற்றுக்கிழமை முருகனாரு
How will you assess the nodal involvement?
Nodal involvement in CECT abdomen and pelvis, sir. If there are no nodes involved, it is N0, sir. If there are 1, 2, 3 nodes involved, it is N1 and
What is
Sir?
N1C? N1C.
இது ஒன்றும் அதிகம் அது அப்படியே போக சொல்லிடுறாங்க போவான் போய் அங்கே போய் கூட்டு வந்து யாரு
Both in
யாரும்
ovarian
தேவையில்லை
carcinoma and colonic malignancy, we have a N1C. So here you will not see a node.
ஆமா வேற போகணுமா அவங்க தங்கச்சியில
It's a deposits.
deposits, yes.
So non-peritoneal surfaces.
நான் வந்துட்டு
Peritoneal surfaces is going
அப்படியே
to see.
போதும் போட்டோம்
So that is one C, very significant. Because though you are seeing normally when we are seeing a mass, the peritoneal deposits, it is always going the advanced. In
Yes.
ovary and colon, even the small deposits you are seeing, it still comes under the 1C.
Yes.
அந்த இடமா பத்தாதுமா வந்து ஒரு 8000
Suraj, any
Sorry.
idea what is a signet ring carcinoma? Signet ring. What is the importance of that? Have you heard that term?
Yes, sir. Signet ring on histopathology, signet ring cells will be visible, sir. It is a high grade carcinoma and metastasis, more prone to metastasis,
பையன் வேணா அவன் எவ்வளவு
aggressive
கேட்கறான்
malignancy.
So Dr. Prabhakar is so somebody is doing consultation.
கார்பெண்டர் அடிச்சுட்டு போறான் அவனே 900 ரூபாய் வேணும் வாங்கி போயிருக்கான்
Yes. Now with this diagnosis in the mind now, how do you
அதனால இப்ப நம்ம
statements? What next investigation? Why? Okay, you can put the CT and describe and tell me why did you the CT was done? What information you want additionally
ஆமா
after the scoping?
Yes, sir. The CECT abdomen and pelvis was done, sir, which was showing short segment heterogeneously enhancing circumferential wall thickness with loss of neural stratification of approximate length of 6 centimeters, sir, suggestive of neoplastic etiology in the proximal and mid ascending colon, sir. The fat planes adjacent to the small fat planes with the adjacent small bowel loops are maintained. Few lymph nodes which were showing central areas of necrosis along the ileocholic vessels were visible, sir, suggestive of nodal metastasis. Along with the primary tumor in CT scan, we have to look for nodes, sir. And if there is any secondaries in the liver, we can see, sir, in CECT abdomen and
What other thing information you might not have written here? What other thing you expect? Right-sided cecal that was 6 months old. Posterior infiltration of the.
so yes, all the fat planes were maintained.
Anything else? No. If it is present, what are the other things which CT? This is your finding, but in the exam we will not ask you finding. We will ask you what other information you will get. Apart local infiltration. So what are the things you would like to know?
Posteriorly, it might infiltrate into the psoas muscle, sir, resulting in.
No, it's not common. So carcinoma, don't expect for a long period of time, in fact, more than 6 months, it doesn't get infiltrated that easily. Before that, something else will happen. What is that? Yes. Posterior ureter, no, ureter.
Yes, sir.
What information? Actually, ultrasound also can give. What is the information? Ultrasound.
Hydronephrosis. Hydronephrosis.
So what-
Hydroureteronephrosis.
So what is the significance of that in case if you find in filing here? Management-
Yes, sir. If the ureter is involved, preoperatively, degescenting of the ureter might be required, sir. And
functionally as well as identification.
yes,
Anything else? So
She's a 40 years old lady. What about the ovary?
yes,
the tubo-ovarian structures are normal, sir.
no.
There,
Again, learn to what sir asking you. See, don't talk about result. That is comes later. Your answer should be to rule out ovarian metastasis. That's simple. Okay, ovarian, and also
ovarian.
also familial. You know that you said some connection is there. Father having a carcinoma.
Yes,
So
yes.
you can also have a ovarian. As well as-
Ovarian and endometrial carcinomas. Right.
So just keep it in mind, all that information. You know, when the questions are simple. What is the advantage of CT over the ultrasound? Simple question.
Yes.
So local infiltration, fat planes, better appreciated here. Liver metastasis, parotid nodes, ascites, all that you can do better even with the ultrasound.
Yes.
What is the information which this cannot give, for which local problem is inside the abdomen, for which, what is that information? It can't give. It can't give.
CT, sir.
Yeah, it means CT. Now, obviously, this is such a 6 months old, you know. Don't tell PET scan. Local means inside the abdomen. So that you will know all malignancies. Today, you start with one procedure. So that
Peritoneal metastasis cannot be visible in CT scan.
All peritoneal metastasis cannot be seen. So
0.5,
you need to step up.
0.5, you know, very small, you know, half.
Multiple nodules. Yes.
Omental, small granulars, almost like, you know, their mets are almost like a granular type, you know, very small ones. Cake tomentum, sometimes you may not pick up.
Yes.
Okay, we can proceed. So next, what has been?
Any investigation you do, you are now all diagnosed this possibility. Any other tumor markers or chemicals you will do test?
CEA, sir. Carcinoembryonic antigen to look for.
What do you want to do?
For prognostic purpose, sir, on follow-up, if the CEA is rising, it might be because of recurrence or metastasis.
What do you mean non-secretors of CEA? There's a group of people, mostly even Indians. They are called as non-secretors of CEA. CEA will not be there. But even then, if there is after the post-operative period, if you have an increase in that CEA level, it will always give you the value. And CEA level is also important for planning. Yeah, suppose there is a metastasis in the liver simultaneously.
Yes.
What you can do?
Yes. Simultaneous metastatectomy can be done, sir, if there is single metastasis or confined to one lobe.
CEA level is very high, more than 100.
Yes, sir.
Then
Yes.
the surgery will be deferred. So investigation is important for assessing the simultaneous doing of the liver surgery or metastatectomy, or for the post-operative assessment of the patient. You have to do this. Any other markers you have to do? In this lady, as we are suspecting, could be a possibility of the Lynch 2.
And
Clinically and by CT, the ovary looks normal, but still you can do one investigation.
CA9.
CA 125.
Yes.
So that will also, because when you are suspecting a young lady some problem, then it's better to do that investigations also. And
Yes.
this patient already there for a long time, liver functions. You said the liver span is only 11 centimeter.
Yes.
So liver function test is also necessarily.
Yes.
Then now you are planning for surgery.
Yes.
Or what is the plan?
Sir, a radical right hemicolectomy, sir.
Right?
Laparoscopic procedure was done, sir.
No, it is an operable tumor.
Yes, sir. In CT thorax, there was no evidence of metastasis.
Okay. So how do you prepare the bowel?
Sir, with like,
You need any preparation, or
yes, sir.
what is ERAS protocol?
Sir, with preoperative bowel preparation, prophylactic antibiotics, and
What do you mean by bowel preparation preoperative? You are going to do enema. Okay. You must read the ERAS protocol. Now,
yes,
electric colorectal surgery. There is no advantage of the mechanical bowel preparation. And there is no advantage of old Nichols regime. All that has been now discarded. Only the prophylactic antibiotic you have to give. And what electrolyte abnormality you are expecting?
hypokalemia,
Because your patient had both vomiting and
diarrhea
diarrhea.
and vomiting. Yes, sir.
So you must be checking for the electrolyte, and you have to verify then how you are making the correction of the electrolyte also. And the patient had severely anemic, you said.
Yes, sir.
So how much blood you will transfuse?
Sir, the patient was already transfused with 3 units, sir. But usually in colon carcinomas, it's not.
Carcinoma, other surgery which we are planning, and carcinoma colonic surgery, is there is any difference in the blood transfusion?
In carcinoma colon, it is not advisable for pre-op transfusion, sir, because of the immune response. The
Good, very good.
decrease in immune response against the tumor cells.
So always
Pre-op transfusion.
cautious on giving a blood transfusion for this. So
Yes.
with all that you are prepared, now we are going for a surgery.
Yes.
So you have done the surgery, no?
Yes, sir. The laparoscopic radical right hemicolectomy was done, sir. Intraoperatively, a large bulky growth present in the right colon.
What is the radical right colectomy?
Sir, complete mesocolic excision along with the ligation of the high ligation of the vessels, sir. Medial to
Okay, go ahead now.
intraoperatively large bulky growth was noted in the right colon, sir, extending onto the ileocecal junction was pulled up. Ileum was looking normal, sir. Multiple small epicolic, paracolic, and intermediate nodes were noted. Rest of the bowel, liver, and spleen were normal, sir. No metastatic deposits were seen in the peritoneum, and no free fluid was there in the abdomen.
How much nodes you are removed?
Sir, is
Any number criteria for the lymph nodes? That's what.
minimum of 12 lymph nodes have to be examined, sir, to rule out to say node negative. Minimum of 12 12 lymph nodes has to be examined as negatives.
So it was how did you manage further?
Sir, patient was started on liquid diet on POD1, sir. The patient tolerated the diet.
That is okay. That's okay. I think what sir wants to know is histopathology final and over. And after that, how is the follow-up? Suppose
How you are going to? Are you happy with this, or you want to continue any treatment for this patient?
Sir, based on the histopathology, if it is a node positive disease, adjuvant chemotherapy we have to give, sir, with 5-fluorouracil.
Will you give neoadjuvant therapy?
No, sir. Neoadjuvant therapy in right colon carcinoma is.
As on what we believe and our textbooks believe, it is not upfront
surgery.
Upfront surgery, or you go for upfront chemotherapy. If there is not operable, you have to go for
yes, sir. Yes. Yes.
Or you go for an upfront surgery. But adjuvant, post-operatively, adjuvant you have to. So
Yes.
how do you follow up with that? What group of drugs normally you give?
5-fluorouracil, leucovorin, and oxaliplatin is given, sir.
What complications you are expecting?
Folfox.
Yes, sir.
Sulfat, oxaliplatin, what complication can produce? What is blue liver? So oxaliplatin is known to produce sinusoidal obstruction. So that produces a blue liver.
Yes.
Nectin can cause a yellow liver. CASH, chemotherapy associated steatohepatitis can produce
Yes.
a CASH is a treatment. Blue liver is for a oxaliplatin we can.
Oxalate.
So what is the prognosis for this?
Sir, and follow up colonoscopy. And after.
No, what do you expect the prognosis for this patient? So will we start with the chemotherapy for this lady, or will you go for any other assessment for her?
Yes, sir. Again, microsatellite instability examination has to be done, sir. Genetic counseling has to be given as family history is present, sir. And first degree relatives has to be examined for any HNPCC associated carcinomas like ovarian, endometrial, and renal carcinomas.
So all these people should, it's better to go for MSH assessment because it gives about the prognosis also, it gives a lot of information, not only on the hereditary possibility of developing.
Yes.
So post-operative, any complication you are expecting?
Post-operative.
Suppose if you see this patient
Anas-
has some obstructive symptoms.
Yes,
Patient
sir.
comes to you with an obstructive symptoms, and how you will proceed with that?
If obstructive symptoms are there, instead of primary anastomosis, instead of primary iliotransverse colon anastomosis, we can do iliocolostomy, sir, from the same.
Suppose you think it is inoperable.
Yes.
What are the signs of inoperability?
Peritoneal metastasis is present, sir, and
Only peritoneal metastasis.
local infiltration posteriorly to.
What is in the metastasis? M1A, M1B, M1C? M1A, a single site metastasis without peritoneal metastasis. M1B, it's a multiple, even pulmonary node nodules can be there. So that's M2, M1B, and M1C is a peritoneal metastasis. So even when you have Krukenberg tumor, when you have a lot of fixity, exactly para-aortic nodes, you have a supraclavicular node, all these are relative contraindication for. So suppose you are having at that stage, what you will do? What are the options you have? What is SEM?
Sorry, sir.
SEM.
Yeah.
Metallic stents can you use?
Yes, sir. Stenting. Yes, sir. Stenting will be.
Self-expansion, metallic stents.
Self-expanding metallic stents. Yes.
So a lot of cases now, when it is things inoperable, because there's no need for going for doing a bypass. Better to,
Yes.
if it is possible, we can do that.
Yes.
More, I think on the left side, no, sir. Bridging the
More on the left side. Left side.
more of the rectosigmoid pelvis.
Normally, right side coming as an obstructive symptoms, and this will be very rare.
Comparatively, the diameter of the colon is more, and so hepatic fracture is one narrow area. So even though you can see this patient with 6 months, she is actually not in true obstruction, correct? But
Yes, sir.
there is some element of partial obstruction in
Yes.
the patient also.
The,
If you-
the interluminal mass is very high, large luminal mass it was
Correct.
looking at.
Yes.
So I think we can stop, I suppose, sir.
Good, Suraj, you have done well. You are very confident, very slow,
Yes.
not.
He has worked hard, sir. He has prepared.
Yeah.
I mean, in the sense, whatever within his capacity. Yes.
It's good.
Thank you.
Best wishes.
Keep
Yes.
the tempo and study well. You can do very well.
Thank you, sir. Thank you, sir.
Any other faculty, Madam Ratna Chopra, Madam, you are there or she's logged in?
Hello.
Yes, Madam.
So, yeah,
Yes.
I'm there.
Yes, Madam.
The candidate is presented very well, sir.
Okay.
Extremely well prepared, and his answers were excellent. I have a question to ask him.
Sir,
Is
ma'am.
he around? Yeah. So, supposing in such a patient, when you clinically examined him and you found
Yes.
a palpable distended cecum, what would your interpretation of this clinical finding be?
Palpable distended cecum. So think ascending colon growth. That's what I think Madam is trying to tell.
Ascending colon growth, and you should treat it as a sign of impending perforation.
Yes.
So you should take this patient very seriously.
Okay.
Well, very well presented.
Suraj, you know
Thank
what
you.
Madam is hinting at? Closed loop obstruction, correct?
Yes, yes.
Yes, yes. Anybody else? Dr. Kanakwel?
I think so. You are now the host. Suraj, you can unshare your PowerPoints.
Yes, sir. Yes. Thank you, sir. Thank you.
Okay, Suraj, if you have any questions, please ask. Suraj, you have any specific question related to you have doubts, you can ask. Okay.
How can we
Yes.
have a doubt when a Senai sir is there, sir?
No, not like that. The presentations are sometimes differ, like loss of weight, since patient did not tell, of course, it should come in history of present illness, but not definitely past history. I think in the GIT, any case when it comes after, suppose patient comes and hematemesis to the hospital, carcinoma stomach or something, he will have loss of weight. When you retrospectively ask him, we tell it in the present illness itself, but little low, because if he says, no, 5-6 months I have been losing weight, like that. Anyway, that may not be true chronology, but I think point emphasizing is it will never become past history. Correct?
Yes, sir. Yes.
Okay, sir.
Thank you, sir.
Thank you, Suresh.
The next speaker is Dr. Deboria Paul. Sir is back. Okay.
I think, good evening, sir. I think Dr. Debopriya from Sri Ramchandra Medical College. Make it full screen, Kana. Make it full screen, ma? Yes. Good luck to you. Please introduce your unit chief, head of the department, and start your presentation.
Good evening, everyone. I am Dr. Debopriya Paul from Sri Ramchandra Medical College, Chennai. Today, I am honored to present in front of you a short case on CA tongue. It was done under the guidance of Dr. C.D. Narayanan sir, our HOD. So, starting with my case, chief complaint, a 44-year-old male, a 44-year-old gentleman resident of Chennai, driver by occupation, came with the chief complaint of ulcer over the dorsum of the tongue and the left side of the tongue since 2 months. HOPI, patient noted an ulcer on the left side and the dorsum of the tongue 2 months back, which was insidious in onset, started as a small ulcer, gradually progressed to the present side, covering the left side and the dorsum. It was associated with pain over the ulcer since 2 months. The pain was insidious in onset, dull aching, which aggravates on eating spicy food, but not relieved with any medication. Patient also gives history of difficulty of protrusion of tongue and difficulty of mouth opening. On further asking, patient says he has history of tongue bite while eating on and off, which used to give him small ulcers, and it used to heal by its own. There is no history of referred pain to ear, no history of excessive salivation, no history of change in voice or difficulty in speech, no history of deviation of the tip of the tongue, no history of halitosis, no history of bleeding or active discharge, no history of dysphagia, no history of loss of weight or loss of appetite, no history of neck swelling. Past history, patient didn't have any similar complaint in the past. He's a known type 2 diabetes type 2 DM, diagnosed 4 years back on insulin. And he's also a case of systemic hypertension, diagnosed 4 years back on antihypertensive. Nil surgical history. Personal history, patient takes mixed diet, normal sleep and appetite, normal bowel and bladder habit. Patient mentioned he used to chew betel nuts 15 years back for 3 years, but after that the patient stopped chewing it. There is no other history of smoking or alcohol consumption or tobacco chewing. Family history is also, there is no significant similar complaint. Summarizing my history, a 44-year-old female, a 44-year-old gentleman presented with an ulcer over the left side and the dorsum of the tongue, which progressively increased in size over 2 months, associated with pain, with history of betel nut chewing for 15 years, for 15 years back for 3 years, and a tongue bite on and off. General examination. Patient conscious and oriented, moderately built and nourished, well hydrated.
Stop.
No,
Please stop. Let the.
yeah, can you, Devapriya, just take, go to the first slide. I know it's a short case. Yeah, just, yeah, next, yeah. What do you mean by dorsum?
The upper part of the tongue.
What you can tell you that straight away you can use the word left side of the tongue. Okay. See, ventral is a different. Okay, anterior, posterior. So you can straight away tell that patient complains of a ulcerative lesion on the left side of the tongue, 2 months duration. And you said all that he had some. Did he have sharp tooth? Next question.
No, sir. We asked. I forgot to mention it, but he didn't had any sharp tooth. He just told he had tongue bites while eating, but no sharp tooth.
So that is an important part, that sometimes people come with a,
और कौन लिया 28 लेना चाह रहे थे, हमने कहा भैया 27 को नसरीन
iPhone 3 please
छुट्टी नहीं है, गाँव जाएंगे।
Yeah, thank you. So what are the other causes for the ulcer on the lateral border of the tongue? See, one of the common side is the lateral border, correct?
Yes, sir.
Yes. Now tell me.
One is the sharp dentature, because of the sharp dentature, and usually when people who chew tobacco, they keep the quilt on the lateral side of the mouth.
What did you tell? Quilt or quid?
Quit. Sorry.
Correct, no? I got you. So what is quid? Since you said quid. What is quid?
It's a mixture of the tobacco leaf with the calcium carbonate.
What is that? All that pan, nicotine, all that, masa. What are those, all this smoke, all this contain, how many roughly some carcinogens? You have any idea? How many carcinogens roughly? Around 600 to 700 carcinogens are present in all these things. Okay, next question. So, why not it is only a lateral border of the tongue? Yes, you should remember always a trauma first, traumatic, ill-fitting dentures, ill-fitting dentures. Yes, carcinoma. If the ulcer occurs in the tip of the tongue, what you would have thought of? Tip.
HPV.
Maybe, I'm not sure. Tuberculous ulcers. Which condition you get pertussis ulcers? Where do you get it? Whooping cough. So these are some of the questions for differential diagnosis of ulcer. Okay, tongue. So there are many causes, including gamma, right? Gummatous ulcers.
Okay.
So all stages of syphilis you get. I think nowadays you people are not saying. I think I will not ask you those questions. Why is your difficulty in protrusion of the tongue?
So when the genioglossus muscle is inflamed, there is difficulty in the protrusion of the tongue.
Basically, you can't move the tongue. That's ankylosing. Not only ankylosing, right? Why difficulty in mouth opening for the lateral border of the tongue ulcer?
For mouth opening, like there is submucosal fibrosis which causes difficulty in the opening of the mouth. Sir.
So what you are trying to tell is it is not due to the ulcer, it is due to the submucous fibrosis, correct? If I understand.
Yes, sir.
Is it that reason? So do you have later you may have to, when you are after your examination finding, you should be able to explain it with submucous fibrosis in your intraoral examination inspection finding. Okay, right? Yes. Anything else? Bleeding is there? More important.
There is no bleeding.
Nothing.
No bleeding, no salivation.
Next slide. Why they complain of pain over the, just they hold like this, like why do they get it?
Involvement of the lingual nerve and the auriculotemporal nerve can cause the pain.
No, you have to tell properly. Means, does the growth involve auriculotemporal nerve or lingual nerve, or what is the connection? Little bit that you should know.
The auriculotemporal nerve.
So where is auriculotemporal nerve? You have
Sorry.
where does it enter? Which area? Where it is connected? It won't come there. No. What are these branches of what nerve?
Facial.
See, facial.
Mandibular nerve, sir.
So
Mandibular nerve. Trigeminal.
So you should. So please, little bit of that reading is required. Okay. See, whenever buccal mucosa carcinoma, tongue carcinoma, they are fairly straightforward cases. So we always tell in this online thing, here you know the diagnosis. Here you know the diagnosis and you are presenting. So you will be only reading related to this case. But in general, we would like to ask you all the related branches of trigeminal nerve, mandibular division, anterior, posterior, then the lingual nerves, ultimate connection to auriculotemporal nerve. So we have got so many branches, almost. So everywhere it's applies. Okay, I think that you should read about that. Sir Karunakaran, sir, please ask few questions. Sir.
Devapriya,
Yes, sir.
if at all this patient is having a referred pain to the ear, as far as what nerve is involved? I think I am repeating the question.
That time it is the auriculotemporal.
Sorry. I'm sorry. Actually, whenever there is an infiltration of lingual nerve, that may lead to referred pain because of it shares the nerve root with the auriculotemporal nerve. So the nerve involved by the lesion is lingual nerve.
Lingual nerve.
Okay. See, if at all the patient is having excessive salivation, what is the reason for excessive salivation in case of CA-tongue?
Irritation of the tongue mucosa causes
Hmm.
the excess salivation.
Hmm.
And
Any other reason? So if at all the lesion is in the posterior one third of the tongue.
sorry, sir.
So if at all the lesion is in the posterior one third of the tongue, the patient may find it difficult to swallow the saliva. So there may be pooling, and we can find out the patients, these kind of patients in the OP on just screening through the OP. How can you identify the patient is having excessive salivation on screening through the OP?
He will carry some handkerchief and repeatedly
These
keep
patients
wiping.
always carry a handkerchief and spitting on and off very often. Okay. And you said there is no history of deviation of tip of the tongue. Which nerve is involved in deviation of the tongue?
So 12th nerve.
Hypoglossal nerve. Yes. Hypoglossal nerve.
Yes, sir. Hypoglossal 12th nerve.
Yes. Yes. What is the peculiarity of that nerve when you compare with the nerves of 9, 10, 11?
It's a purely motor nerve, sir. And when there is involvement, like the deviation is to the ipsilateral side.
Okay.
9, 10, 11 is coming out. I mean,
Yeah, you're correct. Come.
is coming from this canal. Jugular foramen.
Yeah, jugular
and,
foramen. Very good.
And 12th nerve has separate foramen, hypoglossal canal.
Yes, yes, good, very good.
So a few other questions, Debupriya, that asking the same question, common question, lateral border of the tongue or buccal mucosa, whatever, common question. Apart from the submucous fibrosis, what is the other important causes for difficulty in opening the mouth?
So if there is metastasis to the TNM joint.
Oh God. Metastasis to the TNM joint. It's very, metastasis means, you are referring to systemic spread.
Not I mean, extension of the.
Is it that common or anything more important? Yes. Suppose you give radiation to these patients. I'm sorry. What can happen? Now answer one.
Radiation causes fibrosis.
So soft tissue fibrosis in and around. That may include your TM joint also. Depends upon us. Don't say metastasis. Okay. Buccal mucosa to go to TNM joint, very, very difficult imagination. Anything else? What about your masticative muscles?
Involvement of the muscles of mastication.
You know them? Name, you have any idea?
Sorry, sir.
Do you have any idea about the names of them? Where is their attack?
Lateral and medial malleolus, temporalis, masseter.
What?
Lateral and medial?
Temporalis, masseter. No. Go slow. I think you should read. Okay. Pterygoid muscles, you should know. Pterygoid. Okay.
Sorry.
Pterygoid. Okay.
Medial and lateral pterygoid.
Okay. No problem. No. Don't bring the temporalis and all at present discussion. Okay. So we are not talking about a trismus caused by tetanus. What happens in case you heard of tetanus? Tetanus?
I didn't get the question, sir.
Tetanus, tetanus.
Yes, sir, tetanus.
What happens there? Do they get restless?
Tetanus, there is continuous contraction without relaxation. So they might get, sir.
I think, okay, we'll proceed. I think please read about that. You have to read about tetanus also. Since the question asked was read about masseters, read about pterygoid, role of the pterygoids. So difficulty in opening the mouth, all that thing will come into the discussion here. No history of deviation of the tongue. See, lastly, that no history of dysphagia. In what condition you get dysphagia, especially in carcinoma tongue?
Involvement of the posterior 1/3 causes dysphagia.
Posterior 1/3, they may even aspirate, okay? Because food bolus, you know, you want to keep the food bolus, normally tongue has to touch the palate, like that. So they may have a difficulty in movement of that, especially posterior 1/3. This loss of weight and loss of appetite, they are very advanced stage, especially here. Next swelling, what is that you had in mind?
Patient didn't complain of any lymph node by himself.
So, in which disease you get bilateral neck swelling, especially tongue?
Sorry, sir.
Tongue carcinoma, which part of the tongue you can commonly we may get even bilateral neck swellings?
So when the tip of the tongue or the medial aspect of the anterior 2/3 of the tongue is involved, we get bilateral.
You can reconsider your answer.
Sir, the posterior aspect of the tongue goes to the superior deep cervical node, which is bilateral drainage.
Learn as not posterior aspect. Just remember a full word, posterior 1/3. Whenever you speak in the exam, examiner will be happy if you say posterior. Posterior 1/3.
1/3.
Interior 2/3, like that. What is the reason for that?
Because the lymphatic drainage through the bilateral deep cervical nodes.
Lot of crisscrossing of the lymphatic, and compared to anterior 2/3, there is a less keratinization. So more of a aggressive lymphatic spread. Okay. So that's what is the history of neck swelling. So you consider that this could be malignancy, correct? At this stage, correct?
Yes.
Yes. Yeah. Shall we proceed, sir? Karunakaran, any?
Yes, sir. Next slide.
Jailal sir has come? No, not yet. Okay. Yes. Proceed.
Is there any relation between in personal history? Would you please go to the personal history?
Yes,
Is
sir.
there? Can you relate it with sexual history?
Yes, sir. The syphilis can cause oral ulcer. So HPV virus can cause oral HIV.
Yes. Okay, go ahead.
General examination. Patient is conscious and oriented, moderately built, well nourished, well hydrated, no pallor, icterus, clubbing, cyanosis, pedal edema. There is bilateral submandibular lymphadenopathy present. Kornowski's performance status is 100. Vital wise, patient is febrile, heart rate 82, respiratory rate 18, and BP 110/80 mmHg. These are the clinical picture of the patient.
I think just hold on, otherwise we'll forget. Just go back one slide. Sorry to interrupt you. See, loco-regional examination is a part of your disease, whatever you say. Means tongue, so submandibular nodes. So you just say that this has to be told later. Neck examination, I will be explaining. See, you are a postgraduate, not an undergraduate. So
Yes, sir. I've separately mentioned the neck
What
examination.
I'm trying to tell is general examination. In a MS exam case, what we expect if the patient is cooperative, whatever, hydration. What is that you are interested in? Is it, what is it? Is it a vomiting case or is it really malnourished or something like that?
No, like sometime in advance, CA tongue cases, patients stop
Advance.
eating.
You have written they're moderately based and refreshed, correct? No. So what I'm trying to tell is some no paralytic cyanosis, they're being pedal. Okay, pedal edema has become DIMS. That's okay.
Sorry.
That's a spelling. What I'm trying to tell is short case, be very quickly relevant to your exam, whether halitosis is present or not. That's a general exam finding. Patient has told you in the history. So, and say neck examination, I will tell in the later, after the local exam. Right? Okay, go ahead, please.
These are the pictures of the patient. Examination of the oral cavity. On inspection, lips and commissures normal. Mouth opening, there is trismus. Buccal mucosa, there is submucosal fibrosis. Tongue, there is an ulceral proliferative lesion of size 5x4 centimeter present on the dorsum of the tongue and the left lateral border. Irregular margin, raised and everted edges. Surface appears irregular, floor covered with minimal slough. Extension of the lesion anteriorly 2 centimeter away from the tip of the tongue, posteriorly till the junction of the anterior 2/3 and posterior 1/3 of the tongue, medially crossing midline for 1 centimeter, laterally present along the left lateral margin of the tongue. No active discharge or bleeding from ulcer. Difficulty in protrusion of tongue noted. No deviation of the tip of the tongue. Floor of mouth is normal. Teeth, all the dentature are present. Retromolar trigon is normal. Hard and soft palate normal. Anterior and posterior pillars also normal. No tonsillar enlargement. Uvula midline. Posterior pharyngeal wall is normal. On palpation, inspectory findings of size, shape, and extent confirmed. There is mild tenderness, no warmth, variable in consistency. Induration, it is present at the induration present at base, covering 0.5 centimeter around the ulcer. No induration in the floor of the mouth. Ulcer not extending. Ulcer. There is no ulcer. There is no extension of the ulcer to the posterior 1/3 of the tongue. Does not bleed on touch, and gingivolingual sulcus is also normal. Examination of the neck. The left side, there is a single submandibular lymph node of size 1 x 0.5 centimeter palpable, firm in consistency, non-tender, mobile. And right side also one single submandibular lymph node palpable of size 1 x 1 centimeter, firm, non-tender, and mobile. Other systemic examination, CVS S1, S2 present, RS bilateral, no normal ventricular breath sounds, abdomen soft, no organomegaly, CNS, no focal neurological deficit. Summarizing my case, a 44-year-old gentleman presented with ulcer over the left side and the dorsal surface of the tongue, which gradually progressed in size for 2 months, associated with pain on eating spicy food, with history of betel nut chewing for 5 years, 15 years back, and on and off tongue biting while eating. And on examination, there was indurated ulceroproliferative growth of size 5 x 4 centimeter present over the left lateral border and it is the dorsal surface of the anterior 2/3 of tongue, tender, variable in consistency with bilateral submandibular lymphadenopathy.
Sir, I think who was raised, sir? MMC, I'm sorry. Sir, please ask.
Sir, I'm Abhay.
Sir, namaskar, sir.
Namaskar.
Sir, please, sir, please.
Devopriya,
Yes,
You
sir.
talked about tonsillar enlargement on examination. What is it? How do you define tonsillar enlargement? It is not our specialty. It is completely ENT specialty. Why do you want to bring in this?
Since the patient had a palpable submandibular lymph node, so
Correct. Yes, I can
I wanted
understand
to-
you examine the tonsils of the patient, but it is according to me not in your purview, and you are already reaching a diagnosis.
sure, sir.
How will it come in the way of treatment when there is a possibly malignant ulcer of the tongue?
Yes,
See, what
correct.
all I am trying to tell you is you are inviting questions which are not needed.
Sure, sir. Okay,
A
sir.
surgeon with a little ENT knowledge is going to come after you with this sort of presentation. So what is not required should not be required. Just present what is important from the surgical point of view. I'm quite sure Raj Gopal will agree with me.
Yeah, Devapriya, whenever you present your presentation, etc., a lot of English mistake, that's okay. Means not really acceptable, but we can understand. No integration means what?
Sorry,
In this,
sir.
see, I mean, see, computers sometimes, what's called as auto correction, it will do. Because I know in a computer, when you said infection, it will sometimes put it as an inspection. Integration means what? What did you have
Sorry,
in mind?
it was induration.
You want to say? You are written there, no? Induration present in the base, no induration in the floor. Okay.
Induration.
Yeah, okay, that's fine. Can you start with the inspection slide? One inspection slide. Yeah. Yeah, just that lips and bucks. So how did you make out the buccal mucosa submucous fibrosis? Means how does it look like? Because this is the first question which I asked you earlier.
Sir, when I did palpation, so
No. See. What is
sorry.
your title? Title. See, that's why I ask all these questions. Title is inspection. No. How does it roughly look like?
The normal, the glistening of the mucosa is decreased, and it was
Yes. Correct.
more on the rough side.
Rough means
I mean, fibrous skin mucosa.
fibrosis. So white parchment, like, something like that, So pinkish, shiny with the active saliva, all that, luster, that kind of a shininess is lost. So that is how you start. Now you started with the ulceroproliferative growth. Yes, lateral border going to the dorsum, irregular, everted, all that you have written. Does the ulcer has a surface? Because sometimes what happens in the MS exam, some of the examiners will ask, when you set ulcer, swelling has a surface, ulceroproliferative growth. So, yes, see that, floor correct, irregular, edge, proliferative tissue, proliferation, like a cauliflower, correct? You want to see that.
Okay, sir.
Are you getting my point or not?
Yes, sir. Yes, sir.
Generally, we talk in ulcer floor, correct? Edge, margin, correct? Surrounding area. You want to say that floor has got slough as well as this cancerous tissue, correct? No, that's what you meant by surface, correct? So we normally don't bring that into discussion. Anterior 2 centimeter, posterior in the junction, etc. What is the importance of this crossing the midline? Yes.
Crossing, sir, the management.
Yeah, tell me. Yes, correct.
Differs if the lesion is crossing the midline. So the management will differ if it crosses the midline, sir.
Yes, go ahead. Go ahead.
So the management will differ if it crosses the
Okay.
midline.
Okay, we'll come to that under manage. Next. So the ulceroproliferative growth, whatever you have shown in the picture, we can't make out the crossing the midline, but if you have seen, that is okay. Because I just wanted to clarify, is the induration crossing the midline under palpation or inspection itself, you have been able to make out this growth?
Induration palpation it will.
So see your slide, go back to your slide. See, there are few things, correct? Karunakaran sir, please correct this, sir. If show the picture again, because we will not be able to see the picture. Show the picture. Yeah. So I think it is crossing, no, sir? Inspection itself. Yes, go ahead. Go ahead. Variable consistency, what is that?
Sir,
One minute. Local raise of temperature in the intraoral is not at all important. Forget about that, okay? Even in ulcer, nobody talks about local rise. It's only the surrounding area, the leg. You want to rule out cellulitis, edema, all that things. Okay. Inflammatory. So in an intraoral examination, we don't expect anyone to say no warmth. There's nothing like that. Oral cavity is compared. Hello? Yes. So what do you mean by variable? What is variable? Like what?
sir, there was area of hard and firm consistency, so it was variable.
Be specific, most of the examiners want the induration. That's what is hardness. Mostly in the base and some part in the edge. So it's not like a soft tissue sarcoma where you say softer, harder, variable consistency, tumor necrosis, and central proliferative tissue is in the floor, okay, or surface, whatever you said. Does not read onto gingival sulcus. No. Sir, Dalvi sir, I think has raised. Sir.
I just want her to define what is ulcerative proliferative growth in basic MBBS level. What do you see in an ulcerative proliferative growth?
Sir, in ulcer proliferative growth, there is
Let's define ulcer.
Sir, ulcer is the breach of the normal continuation of the mucosa or.
Correct. I agree.
And
Now,
following that.
when you see an ulcer, you must have seen diabetic ulcer, whatever ulcers. When it becomes proliferative, what are the changes that you see?
So there is excess granulation present, and
Granulation is in the floor of the ulcer.
like the edges.
You got to differentiate to me between edge and the margin.
Sir, edge
when will you call it proliferative? It will be margin which will be responsible or the edge which will be responsible? That's the problem. Sure. Rajgopal, I think you'll have to explain to them. I'm a retired person. Thank you.
Sir, no, sir. I think the sir wants to basically highlight that so much proliferation has taken place in the tumor tissue. That's how it has become ulceroproliferative. So, and sir, we will proceed now.
No, I will just take 30 seconds.
Please, sir. Please.
All PG students should realize that the most proliferative region is the edge, where cells are multiplying all the time, and if it is malignant, it overgrows. So you have either everted edge or a what do you call, Rajgopal, can you tell me? Everted age.
Yes.
So it happens between squamous cell carcinoma and basal cell carcinoma.
Correct.
Looking at only the age, one can make out what you are dealing with. And these are important clinical examinations which all PGs should remember. Okay. Biopsy becomes a secondary investigation. It doesn't know. We know clinically this is malignancy. That's all I wanted to say, Devapriya. Examine patient properly. It gives you complete diagnosis. Thank you so much.
Yes. So basically, also no proliferative lesion, whatever extent you say. Yes, you have written retromolar extension is not that very important point. And floor, yes, midline you have mentioned. Induration is more important than the size. Why is that? Why is that?
Extension, actual extension of the.
Correct. So
Carcinoma.
especially two areas which are equally important squamous cell carcinomas. One is the tongue, another is in men, of course, penis. Okay, that is a very important. Both will have induration. Both are squamous cell carcinoma. Both that extent is so important for a decision making, soft tissue invasion, etc. Right? So induration you should look carefully. The hardness due to what?
Fibrosis.
Yeah, okay. So say desmoplastic reaction, fibrosis.
Desmoplastic reaction.
Sir, can we proceed, sir? Karunakaran, sir.
Sir, let me ask one or two questions.
Please, sir, please.
See, you mentioned ulcer not extending into the posterior one side of the tongue. Yes?
Yes.
What is the anatomical demarcation between anterior two-third and posterior one-third of the tongue?
Sir, the sulcus limitans, where the circumvallate papillae are there. That is the part differentiating the anterior two-third and posterior one-third.
What else?
Only the anterior two-third is the mobile part. And
Can I come in here?
Yes, sir, you can chip in, sir.
What is ultimobronchial body? That is exactly what sir is trying to ask you.
it is the part where the posterior part develops.
And
Posterior
what is the
one-third.
anterior known as? Because that is the importance of the thyroglossal cyst, etc., etc. Karunakar Saran, please take over.
Yes, sir. Okay. What other anatomical things delineate the posterior one-third and anterior two-third? Anterior pillar of the tonsillar fossa, uvula. Okay. So the things beyond that are posterior one-third and anterior two-third of the tongue. And you have mentioned about gingivolingual sulcus, normal, yes?
Yes.
What is the inference I can get from this?
Like there is no growth which has extended to the tail.
So what other sulcus you know in the oral cavity?
Gingivobuccal sulcus.
Good. Gingivobuccal sulcus, gingivolabral sulcus. So here, when you say gingivolingual sulcus is normal, that means there is no involvement of the floor of the mouth. Am I right or wrong? So you are saying there is no involvement of the floor of the mouth.
Yes.
That too on the left side also. So you said the lesion starts on the lateral border on the left side.
Yes,
and it has extended towards the midline and crossing the midline. Even on the left side, there is no involvement of the gingivolingual sulcus. Is it right or wrong? Because We
Yes,
are
sir.
in with virtual classes. We are not
Yes,
seeing the
sir. No,
patient.
there is no involvement of the gingivolingual sulcus on the left side also.
Okay. Next slide. Next slide, please. Next slide. Next.
When you give a final summary, the diagnosis, if you can mention if there's any more details about consistency, mobility, fixity of the hard node, it will be still better. Okay? You understood?
Yes, sir.
Was it hard or whatever, mobile or size criteria? See, you are written single, firm, one you are written firm, non-tender. Okay, mobile. Okay, that's fine. So that means it is a mobile node, but 1 centimeter, correct? Yes.
Yes, sir.
Okay. Firm, all right, non-tender. That's fine.
So, sir, my diagnosis is yes, sir.
In your diagnosis, you said it's a carcinoma tongue. Well and good, but you said it is N2. Whether it is N2A, B, or C, you haven't mentioned.
Sir, it is N2C, sir, because bilaterally the submandibular lymph node is involved, sir.
So even though the size of the node is less than 3 centimeter, if it is on the contralateral side, it is N2C. It is N2C. That
Yes,
is the
sir.
point I want to stress. Some
Yes.
people may think the size is less than 3 centimeters. So I don't know why you have put N2 alone, why you have not put N2C. I want to know the secret.
Nothing, sir.
So you are able to answer it is N2C, but you have not written N2C. Is there anything hidden?
No, sir, nothing.
How will you manage?
Sir, we will to confirm our diagnosis, we will do edge wedge biopsy, and we will do MRI of the neck to see the depth of the invasion. And for staging, we can use CT. And
See have you ever taken a biopsy from a CA tongue?
yes, sir.
Can you describe how to take a biopsy from a CA tongue?
Sir, we have to take both the area which has maximum suspicion of the malignancy along with the normal area of the tongue, and it should be towards the anterior side.
See, when you put your finger inside, the patient will bite you. Yes or no?
No, sir, under general anesthesia, we will do, sir.
You are going to take the biopsy under general anesthesia, putting an endotracheal tube. I think you are complicating the issue. Sir, Rajagopal, sir, would you please chip in? See, actually, it's very difficult to take an edge wedge biopsy in a CA tongue because the tongue is a mobile organ. When you put your, if you put local inside, inject local, the tongue will withdraw back. So you have to get hold of the tongue with the help of a gauze or a Alice forceps. Then you can inject local or make an edge wedge biopsy. Better is we can go for a punch biopsy. Somebody has brought in the chat box. You can get hold of the tongue, can take a punch, and that too in the posterior aspect, which may very well define whether it is positive, or I mean, how much posterior it is. We can, but it's a bit difficult. So taking a biopsy on the anterior aspect seems easier. Punch biopsy is an easier option. That too, when it is more and more deep inside. When it is in the posterior one third of the tongue, the option is only punch biopsy rather than edge-wedge biopsy. Whereas in the anterior 2/3 of the tongue, we may go for an edge-wedge biopsy that is more anteriorly. What will you find in your biopsy report?
Biopsy, sir, will look at the differentiation, like well differentiated, or like the type of lesion.
Well, what type of carcinoma you expect in this?
The squamous cell carcinoma is the most common. So
Yes, if at all, if at all the biopsy report comes as adenocarcinoma, what could be the cause, or what could be the origin point?
adenocarcinoma, I'm not sure.
The minor salivary glands, if at all the biopsy report comes as adenocarcinoma, it is from the minor salivary gland. Most of the time, it is squamous cell carcinoma, and you have taken a biopsy, you have graded based on the differentiation and presence of keratin pearls, etc., etc. Then you said MRI of the oral cavity. No need for MRI of the oral cavity because it is confined to the tongue. Am I right or wrong?
Yes, sir.
You can do an MRI of the tongue, that too, to assess the extent
Depth of
the
invasion.
extent of the tumor, depth of invasion, and to find out whether there is any gingivo lingual sulcus involvement or not. All these things can be assessed. Okay, then
MRI also helps to midline crossing is there.
Agreed. Well and good.
Sir, so after confirming and staging our case, we will go ahead with subtotal glossectomy.
Please stop. See, the investigation as far as a malignancy is concerned can be divided into three. This is my personal opinion. First one is investigation to confirm the diagnosis. Number two, investigations to stage the disease, or investigations to assess the extent of the disease, whether the patient is having any distant metastasis or loco-regional disease or local disease alone. Then third one is investigations to assess the general condition of the patient, whether the patient is fit for surgery or neoadjuvant chemo or neoadjuvant RT, whatever it is. So we can divide the investigations into three. One, investigations to confirm the diagnosis, investigations to stage the disease, then investigations to assess the general condition of the patient. We have completed the part 1 only. What about the part 2 and part 3?
For staging, sir, we can do CT, sir.
Yes.
And for general condition of the patient, we'll do the routine blood investigation like CBC.
Yes.
After that, we can proceed with the surgery.
Okay. What will you do then? What is the treatment?
Sir, for this case, we can, since there is no metastasis and there is N2C, so we will go ahead with the subtotal glossectomy with bilateral modified neck dissection, modified radical neck dissection.
Why bilateral modified neck dissection? See, always the carcinoma of the tongue is considered as an aggressive disease. Why not radical dissection on one side and why modified radical on other side?
The radical is like we have to sacrifice the uh, the three structure we can save in modified radical neck dissection.
Yeah, my point is you are saying bilateral modified radical neck dissection. My choice is radical dissection on the ipsilateral side and modified radical dissection on the contralateral side. Do you agree with me or you want to stand on your point?
Sir, I'll go ahead with modified bilaterally.
The advantage of preserving this thing. See, since C8, whereas if it is a C8 cheek, I may agree with you. As far as the C8 tongue is concerned, I may not agree with you. I'll go for a radical neck dissection on the ipsilateral side, removing all the fat, fascia, and lymph nodes along with the three vital structures, as you said, sternomastoid, spinal axillary nerve, and IJV. Because most of the nodes are in and around the IJV. So we have to remove the IJV for the facilitation of removal of all the fat fascia and lymph nodes, starting from level 1 to level 5. Yes.
Okay.
Can we do radical neck dissection on the same sitting on both sides?
Sorry, sir, I don't know.
You
Sorry,
can't
sir.
do. You can't do. If we do radical neck dissection on both sides, if you ligate IJV on both sides, patient will go for a cerebral edema and patient will die. So in that case, if you want to do radical dissection on both sides, we have to give an interval of at least 6 weeks. You do radical dissection on one side, ipsilateral side, give an interval of 6 weeks, then go for radical neck dissection on the opposite side. Better is we can do radical on the ipsilateral side and do a modified radical with preservation of IJV on the contralateral side. That is safer aspect. Yes.
Yes, sir.
What are all the things you are removing in modified radical neck dissection?
Sir, level 1 to 5 lymph nodes, sir, and the submandibular gland and ansa cervicalis. In type 1, we will be sparing the 11th cranial nerve. Type 2, we will be sparing 11th cranial nerve and the IJV, and type 3, we will be sparing 11th cranial nerve, IJV, and sternocleidomastoid.
Okay, already I think this question is asked. Is type 3 modified radical neck dissection and functional neck dissection are one and the same or different?
The type 3 is the functional neck dissection of modified neck dissection of Boca. Call it.
You are saying type 3 modified radical neck dissection and functional neck dissection are one and the same. Yes or
Yeah,
no?
yes, sir. Yes, sir.
No. Functional neck dissection is exclusively meant for papillary carcinoma of the thyroid, where we won't get nodes in level 1. We won't get nodes in level 1. We do the same MRND type 3 without removing nodes in level 1. So the difference between a modified radical neck dissection type 3 and functional neck dissection is level 1 nodes. In functional neck dissection, we don't remove level 1 nodes. Yes, and that is exclusively meant for papillary carcinoma of the thyroid. No other place you can't use the term functional neck dissection. Got it? And you said
Yes, sir.
you can in type 2 neck dissection, you remove, you preserve
Spinal accessory and IJV.
the spinal accessory and
IJV.
That means you are removing the sternomastoid, yes or no?
Yes, sir.
Then you remove the spinal, sternomastoid. What is the purpose of preserving the spinal accessory? That is the question of Jatin Shah, a surgeon at MSKCC, Memorial Sloan Kettering, and he has put forth that question. And there is a school of thought, and a certain percentage of surgeons are following his thought. What is the purpose of keeping spinal axillary nerve when you remove the sternocleidomastoid?
It
he
supplies trapezius also.
Yes, yes. That is one advantageous point is it supplies trapezius also, so trapezius can be spurred. Whereas Jatin Shah says in type 2, he preserves spinal axillary and sternomastoid and sacrifices the IGV. That is the thing followed by Dr. Jatin Shah. Okay. And whenever you do a neck dissection, there is one thing we may inadvertently injure at the lower aspect. That is somewhere near the supraclavicular region, that too on the left side. What is that structure? That is present on the left side.
Thoracic duct takes turn.
Yeah, good. Thoracic duct. If at all you injure the thoracic duct, what will happen?
Then lymphedema of the left upper arm and the bilateral lower limb.
No. If at all you injure a thoracic duct, there is a continuous leak of chyle. Continuous leak of chyle. How will you manage? If you on table, if you are able to identify, well and good, you can ligate it. Whereas in the post-operative period, if at all you find it, it's very difficult to manage. You have to go for a resurgery. It is much more difficult in identifying. Otherwise, you can put a G-pad tightly and put a elastocrete bandage for three or 4 weeks. And if it is cut clearly, it will collapse and fibrose and it will get settled. If it is partially cut, then again it's a problem, it may not settle. Okay, if the patient does not want to undergo surgery in this case, what's your option?
Radiotherapy. You can take it.
Because there are multiple types of radiotherapy, brachytherapy, teletherapy. What brachytherapy you want to?
Sorry, sir.
See, why don't you use a teletherapy? What are the types of teletherapy?
Sorry, sir.
See, commonly we use telecobalt and Linac, linear accelerator. The point is the patient has to open his mouth and lie down in the same position without changing his neck or head for half an hour or 1 hour. It is very difficult for him. He may change and the point of focus of the radiation may go to a different point. So teletherapy may not be suitable here. Here, as you said, brachy is the ideal choice. So you can do a brachy to the primary. What about the node?
Chemotherapy, like you can give, sir.
You can do radiotherapy to the node also, or you can go for a surgery. And chemotherapy is not a primary line of management as far as the oral malignancy is concerned. For oral malignancy, the primary management is either surgery or radiotherapy. Chemotherapy comes as a secondary management. If at all chemotherapy can be used, what is the drug of choice you choose? Platinum-based drug, cisplatin or carboplatin with ifosfamide, or so many combinations are there that can be managed by the medical oncologist. Okay, what is the toxicity that can be produced by cisplatin?
So what is the
toxicity produced? See, all the chemotherapeutic drugs produce
nephrotoxic and neurotoxic.
Good, nephrotoxic. Once after radiotherapy, how will you assess the patient's response?
MRI we can do.
Yes, we can do an MRI and find out how much regression. Response.
Yes.
What is complete response and what is partial response? What is no response?
Complete response means there is on MRI there is no lesion we can see. Sorry, sir, I don't know the exact.
You better go and read. Okay. Sir, Rajagopal sir, could you please chip in? Or any other faculties? Kanavel sir? Okay, Debopriya, if you have got any questions, any doubts, you can ask in this forum. We'll try to clarify your doubt. Can I, sir? Are there any other faculties? I think no one is chipping in. You can ask. It's time for it is your time to question us. If there is no question, faculty, shall we wind up the session? I think no one is responding. Yes, you don't have any questions. Shall we wind up?
Yes.
Thank you, faculty sir. Kanavel sir. Sir, I think no one is responding. I think we can wind up the session.
Yes, sir.
Someone is chipping in, I think. Let's wait. Okay. Thank you, Debopriya. You have done reasonably well and you have to read little bit. I think you have completed 16 or 18 months in your course. Yes? You joined in last February 2022. Or before that?
February.
Yeah. Okay. You are more than, what do you say, more than good. I'm expecting a level and you are beyond that level. I think if you work hard little and with your common sense, I think you can clear your exams very well. Thank you, faculties. We can wind up the session. Thank you.